Thank you for joining me for this presentation today on applications of LSVT BIG to neurological conditions outside of Parkinson's disease. My name is Laura Gusé. I'm a physical therapist and one of the LSVT BIG training and certification faculty. I also serve as the Chief Clinical Officer of LSVT BIG for LSVT Global. A few disclosures before we get started. I have both financial and non-financial relationships with LSVT Global, including a preference for the LSVT BIG treatment techniques, and I'm an employee of LSVT Global and receive lecture honorarium. Here are the learning objectives for our short presentation today. We'll be defining LSVT BIG and the goal of treatment in case you're not familiar with this treatment. Describe the assessment process used to determine if LSVT BIG is appropriate for a patient, specifically in this case, a patient without Parkinson's disease, and then summarize emerging research that uses LSVT BIG for neurological conditions other than Parkinson's disease. So if you're not already LSVT BIG certified or don't know a lot about it, here is what it is in a nutshell. It's an intensive, amplitude-focused physical and occupational therapy intervention developed originally for people with Parkinson's disease. It is a standardized 1-month treatment protocol, but it's not really a cookie cutter approach. Within the protocol, it's very much customized to meet the unique goals of each person that you treat. It has to be delivered by therapists who are certified in LSVT BIG or LSVT Loud. Again, it can be adapted or progressed to meet the needs of a range of individuals. So it's not only for people with early Parkinson's disease, but it can be applied to people with all stages of Parkinson's disease, along with other neurological disorders as well. The goal of LSVT BIG is to restore normal movement, optimize their movement and their function so that they can then use that more normal, better quality movement in everyday life. What we found over the years through research on LSVT BIG, and all of this was independent research, is that training amplitude seems to improve other levels of motor output. So with that singular cue of think big, when you're training patients, in research, they found improvements in trunk rotation range of motion, stride length, speed of walking, speed of reaching, cue to reaction time, UPDRS motor score, balance, decreased fall risk, coordination, improvement with ADLs, dual tasking, and improvements in occupational performance as well. Some of the references are listed here, and you can find those at the end of the slides and in your handouts as well. But there are other non-PD disorders that you could consider using LSVT BIG for, and this is not an exhaustive list. These are just some of the ones that they're most commonly used for currently by LSVT BIG certified clinicians. And in this short presentation, we'll be going through highlights of some of the newer research that's come out on stroke and a case study on normal pressure hydrocephalus. So if you do LSVT BIG for other diagnoses, one question that people ask is, do I do the same treatment protocol? And yes, you're going to use the same framework, the same LSVT BIG protocol that you always use. You're just simply applying it to a different diagnosis. So why might LSVT BIG help other conditions? A few core reasons. One is it really integrates all of the well-known principles of activity-dependent neuroplasticity and motor learning that you can read about in the literature extensively. And these principles are found to help people with other neurological conditions as well. In LSVT BIG, we use 5 specific teaching techniques. Briefly, they're modeling to train movement. So instead of explaining how to use movements, we show them how to make the movements. We drive their effort, we drive their amplitude, we shape the movement. So instead of saying turn your hand up, we might physically shape or facilitate that movement. We also work on stabilizing their behavior. So when they do it right, we give them very specific feedback of saying, yes, that was, what a big hand or a big reach really feels like. Do it again just like that. And then we also work towards calibration, which we'll talk about in a second. But basically, all of those teaching techniques work very, very well with other neurological diagnoses as well. It also promotes intrinsic feedback. So we really try to train our patients through something called calibration training to reset their internal motor program. So if they're, for example, maybe leaning to the side or not swinging their arm because of their neurological diagnoses, we train them how to move or how to position themselves more normally and what that feels like, so that after therapy is over, they can continue moving in that new normal way, even if it doesn't feel completely normal to them internally. Generalizability is sometimes a struggle for clinicians. I'm sure many of you listening have had difficulties at times getting patients to transfer the things that you've worked so hard on in therapy to everyday life. So during therapy, you get them walking bigger, you get them moving bigger. Maybe you're working at ADLs, like, getting dressed, and they can do it in therapy well, but for whatever reason, they're not translating that to doing it in that same way at home, and they're not transferring it to untrained tasks that you might not have worked in therapy. So LSVT BIG really tackles that. And again, through calibration training, this is something that can be applied to patients of many different diagnoses. Now, think about the cue that we use in LSVT BIG. Everything we say is think big. We say big hands, big posture, big reach, big steps. Because in Parkinson's, we're working on overriding bradykinesia and hypokinesia. However, in some disorders, what we're really working on is control of movement. If you think, for example, of a person who has an ataxia, or maybe someone who's gone through deep brain stimulation, they might not need to move bigger. They might need to learn how to control their movement, control their posture. But that same cue can be used to taught them really how to control their movement. So just because they have a diagnosis like ataxia, hyperkinetic movement disorders, impulsivity, doesn't mean that we can't use LSVT BIG. It just means that the meaning, the definition of what we're educating them in is just a little bit different. So here's how you decide if LSVT BIG is appropriate for a given patient. First, is there a muscle activation deficit that's central in origin, such as someone who has maybe hemiplegia from a stroke, or reduced arm swing as a result of some chronic impairments related to their MS. So yes, they can move that arm, they can move that body, but they're not eliciting that movement. Is there a sensory processing problem? And again, with many neurological disorders, same examples, stroke and MS, we do see that quite often. And how does your patient react to stimulability testing? So when the LSVT BIG certified therapist models bigger movement and drives the patient to do that movement bigger, whether it's getting out of a chair, walking down the hallway, etc., can they move bigger? And is that bigger movement better quality movement? So those are two key questions and observations that therapists make. Is your patient medically stable? Of course, if they're recovering from something like a surgery, illness, an injury, something like that, they really need to be healed before they're ready for an intensive treatment protocol like LSVT BIG. And if the patient has cognitive impairments, do they have a support system in place? They can benefit greatly from a treatment like LSVT BIG, which has a simple, single, redundant cue of think big, but they really need someone to help them carry over to everyday life and perhaps coach them as well. So the ultimate decision is based on your assessment, stimulability testing, and clinical decision making. And that's something that we train in the LSVT BIG training and certification course. So lastly, let's look at some highlights of emerging research on use of LSVT BIG in non-Parkinson's disorder. One of the first studies that came out was a case study on two clients who had a stroke, one 3 years prior and one 12 years prior. And they wanted to see if LSVT BIG could impact their occupational performance goals. So this was a single case experimental design. LSVT BIG trained 3 out of 6 of the client's chosen tasks. They used the Canadian Occupational Performance Measure and the everyday arm use in the community and home, and they measured them repeatedly. The results were positive. They found performance improved on either the self-assessment or blinded rater assessment in all but one activity, and that was not only the trained activities, but the untrained activities as well, speaking to the generalizability. It's a hard word for me to say. So one client reported doing things that he hadn't done in a long time since before his stroke. So he could do really high level things like clean out his garage. He did laundry, prune trees, even said he could light a campfire and chop wood. So really impressive. And that was the one that had a stroke 3 years prior. The other client, who was 12 years post stroke, also showed significant improvements subjectively. So one of his quotes was, and I'll read it here for you. So now, if I'm not sure in a situation, I can start and go from there. It gave me the confidence to try a movement because I had the knowledge of how to do it. I was unsure about what more I could learn, but I could see improvements in control of my elbow and balance on the bike. I did not expect that progress would happen in 4 weeks. And so, sometimes as clinicians at the outset, we think, oh gosh, that's really a lot, 16 visits in 1 month. But really, it's one short month out of their lives that can make a huge impact for years to come. And this person was already 3 months past stroke. Many of us would think, oh, they're at where they're at, but clearly they still have capability of improving more, potential of improving more, if we give them a chance and treat them intensively. And then the quote from the researcher was, LSVT BIG is a promising intervention to improve occupational performance. And this was an OT delivered treatment protocol in this case. Further research is required to clarify elements of the program essential to improving occupational performance. In 2018, just a year earlier, Profit and colleagues had also looked at application of LSVT BIG to a person with stroke, and this was someone that was 52 years old, a female. She had stroke 29 months earlier. She had mild to moderate hemiparesis of her left arm. She was still functioning. She was independent with her ADLs, but she really developed kind of a learned non-use of her left arm and started relying solely on her right arm, even with traditionally bimanual tasks. So she showed improvements in performance and satisfaction on the COPM, the Wolf motor function, and she restored completely normal active range of motion of her affected arm, and she no longer had a significant spasticity in her left elbow. The improvements on the COPM and Wolf motor function test did exceed the MDC. So the quote from the researcher was, the improvements Brenda made in her performance of occupations and engagement in new occupations reflect the saliency of the LSVT BIG interventions. Subjectively, she reported her movements were smoother. She was doing things more bimanually, like she could, hold a glass and pour lemonade into it. She was using both of her hands to wash her hair. So just remember, as OTs and PTs, saliency is important. It's one of those principles of neuroplasticity. And we know that it's really key for brain reorganization. This is consistent not only in the Parkinson's literature, but in the stroke literature as well. And the last study I'll talk about related to stroke was published just in 2021, looking at feasibility of LSVT BIG in stroke. And so they wanted to determine the feasibility, acceptability of delivering LSVT BIG to people with stroke, the chronic stroke, and also to determine the clinical effects of the intervention on occupational performance of upper extremity motor function. So they did LSVT BIG per protocol, 5 patients, 3 males, 2 females. They ranged anywhere between 8 months post-stroke and 89 months post-stroke. So here are some of the outcome tools that they used. I won't read them here. You can read them for yourselves. And the results, 4 out of 5 of the patients rated the performance and satisfaction on the COPM higher after LSVT BIG. 3 of the 5 participants completed the LSVT BIG intervention first, and then 1 of the 3 maintained higher after the maintenance period. Their average time on the Wolf decreased in 4 out of 5 participants. and 3 out of 5 decreased their time by 16%, which meets the MDC. In the past, they improved in safety, adequacy, and independence scores. And on the promise, categories that improved include anxiety, depression, and ability to participate in social roles and activities. Again, really promising early findings. The quote here was, some of the participants also self-reported engaging in non-prescribed activities in the home, generalizing improvements to performance in related activities. And that's what we do. We only have a very short time in therapy, and we know that when a person has a chronic neurological condition like a stroke, it affects everything that they do. And that's really the goal, the dream, right? Isn't it, for therapists, for them to learn something in therapy from us and then apply it to everything that they do so that their whole life is better. This last study I'll go through was a case study looking at the use of LSVT BIG in someone with idiopathic normal pressure hydrocephalus. This was a 62-year-old male diagnosed 16 years. Prior to the study, he had multiple falls, which you know is common with NPH. He underwent LSVT BIG per protocol. He did cancel once. His sessions had to be longer than 1 hour because of his distractibility. And then 7.5 months later, he returned for 5 tune-up sessions. So they looked at his BERG and his ABC, the Activity Specific Balance Confidence Scale. Both of the scores on there improved beyond the minimal detectable change post-intervention. Unfortunately, they didn't see any changes in his tug scores or his 5 times sit to stand. But the good thing is that he no longer fell backwards when he was doing them. And the number of steps with turning during the tug improved quite a lot. So he was also able to perform floor transfers in less time. And then this is a survey, not published, but a survey that was presented at the MDS meeting in 2020. And LSVT Global did a survey of LSVT BIG certified clinicians to ask them about how they were using LSVT BIG outside of Parkinson's disease. And 541 LSVT BIG certified PTs and OTs responded to this online survey. And you can see that 26% used it for secondary Parkinsonisms and Lewy body dementia, 20% PSP, and 19% ataxia. And their subjective ratings of how effective it was were very high. So really, really good to see that this was in the agree or strongly agree category of whether it was effective or not for them. Other diagnoses you can see here less often were stroke, age-related balance changes, MS, and Alzheimer's. And again, some nice ratings here, self-ratings by the clinicians of whether or not they felt it was effective. So in summary, LSVT BIG is an evidence-based program. There's a lot of research on it, developed for people with Parkinson's, but yes, you can use it for other diagnoses to improve ADLs, mobility, occupational performance. You have to really go through a decision-making process. It's not for everyone, and so LSVT BIG certified clinicians are trained on how to determine if someone will be a good and appropriate candidate. Early research shows that LSVT BIG was helpful in improving function in arm use in some people post-stroke and mobility and balance in someone with NPH. Occupational performance measures as delivered by OT are really useful in identifying tasks that are meaningful to a client. So keep those in mind if you're an OT. Certainly there are limitations. These are case studies and really, really early research. So we do need continued research, and hopefully someday we'll have that. But promising to know that there are treatments out there that can help individuals and have strong foundations in principles of neuroplasticity and motor learning. So with that, I thank you for joining. If you ever have any questions, you can always email us or visit our website. And now I'll pause, and I think we have 10 minutes of Q&A.